Hi everyone, it's me, Sandy Cruz of Sandy K Nutrition, Health and Lifestyle Queen. For years now, I've been bringing to you conversations about wellness from experts from all over the world. Whether it be suggestions in how you can age better, biohacking, alternative wellness, these are conversations to help you live your best life. I want to live a long, healthy, and vibrant life. Never mind all those stigmas that as we reach midlife and beyond, we're just going to shrivel up and die with some horrible disease. Always remember, balanced living works. I really look forward to this season. Hi everyone, welcome to Sandy K Nutrition, Health and Lifestyle Queen. Today with me, I have Dr. Alan Christianson, and today we are going to break down the thyroid gland. You all know I have been living without a thyroid gland since 2011 due to thyroid cancer. I'm also going to have Dr. Amy Horniman come on in a couple of weeks to talk about thyroid as well. Now, the one thing I do want to say is this. There may be some things on my podcast that I don't necessarily agree with. I personally believe iodine is an extremely important micronutrient that is essential for thyroid hormone production. Whatever you do here on my podcast, just so you know, no matter who my guest is, it's so important for you to critically analyze if something makes sense for you or not. So the opinions that are on this podcast are not necessarily my opinions, and my opinions are only my opinions. None of this is medical advice. It's merely just to provide you with the breadcrumbs so that you can go on your trail to find out what makes sense for you, for your own path. I just wanted to make that clear. I also believe so heavily in freedom of speech and freedom of expression. So I have people on my podcast from all areas. And just because there may be some things that I may not agree with does not mean that they don't have a platform on my podcast. And it also does not mean that they're wrong and I am right. There's so much of that in the world, you guys. Now, one of the things that I do is I educate. In February, it's going to be 5 years since I started this podcast. And it's just a platform just to provide you with some information, just to help you age better. Maybe some alternative health solutions, maybe some other solutions that are really indicative of stages of life like menopause or male menopause even. So I just wanted to ask for you to go and rate and review my podcast and share it with a friend or share it with somebody who might benefit or share it on social media. I'm not quite sure what's happening with Instagram these days, but they're really not showing a lot. And it's not just me, it's a lot of people. So I don't know if that relates to the election coming up. I really don't know. But it's just more important now than ever that you share my content through however you can do so, just so that other people know that I'm here and just so that I can keep getting amazing guests each and every week. I'm also going to ask you to follow me on all of my social media platforms, Instagram, Facebook, TikTok. I'm on Threads. I'm not really on Twitter much at all, but it's Sandy K Nutrition everywhere that you are. I haven't been posting so much on YouTube because they sent me a very clear email saying that they weren't going to show something because it doesn't support the WHO. Meanwhile, it was a video about my mom's actual results on her bone mineral density scan. And apparently, to YouTube, this is medical misinformation. Yeah, it's crazy, you guys. Meanwhile, this is fact. Yes, it's N of 1, but it's fact. So I've been a little bit disenchanted with YouTube. I've kind of put off Rumble as well. And I have sent off my book proposal to a couple of literary agents. We'll see where I'm at with that. But if you want a taste of what's to come in my book, follow me on Substack. Substack is a great platform for writers and journalists just to be free with their speech. And there's all kinds of topics there, but I have many of my short essays there. And I believe a lot of them are going to be in my book. So you're going to get a first glance of my book. So go follow me there. It's Sandy Cruz, SandyCruse.substack, substack.com. All of this will be in the show notes in the description. And please, please, please don't forget to share my podcast and rate and review. That's your homework. And now let's cut on through to this interview with Dr. Alan Christianson, all about the thyroid. Hi, everyone. Welcome to Sandy K Nutrition, Health and Lifestyle Queen. Today with me, I have a special guest. His name is Dr. Alan Christianson, and he is America's top naturopathic endocrinologist, New York Times bestselling author, and one of the most widely respected early pioneers in natural thyroid care. He has decades of clinical care to help you manage thyroid disease safely. He's written the Thyroid Reset Diet, the Hormone Healing Cookbook, the Metabolism Reset Diet, the Adrenal Reset Diet, the Complete Idiot's Guide to Thyroid Disease, and more. Dr. Christianson was a member of the premier class of Sonoran University of Health Sciences College of Naturopathic Medicine, graduating in 1996. He has been actively practicing since graduating in 96 and has over 100,000 patient visits. Dr. Christianson is the founding president of his medical school's alumni organization, and he is also the founding president of the Endocrine Association of Naturopathic Physicians. And today we're going to talk about my favorite topic. Everybody who listens to my podcast knows I will speak about thyroid until the cows come home. So we are going to talk about thyroid health, but from a functional integrative perspective. And then we're going to just tie in menopause, because most of you who listen are in perimenopause or close to menopause or past menopause. So we're going to kind of tie that in as well with Dr. Christianson. So with that, welcome. I'm so happy to have you here.
Well, thank you, Sandy. I'm happy to be here with you. This will be a lot of fun.
Yes, I think it will be too, because this is your forte and you've been doing this for so long. And for those of you who are listening, I was saying to Dr. Christianson how I read some of his books or research, or I started following him soon after I had my thyroid removed. And that would have been in 2011 now. So it's a long time ago. And so it's kind of funny. I'm like almost like a little starstruck. I'm like, I've been following you forever, and now I get to record with you. So I am really honored, and I would love to hear a little bit about your story and how you got so involved in thyroid health.
Yeah, kind of an odd thing. As a kid, I had health issues. I had complications from cerebral palsy, epilepsy, and I was just horribly uncoordinated. I was like the clumsiest kid you could imagine, and I couldn't really do sports or things like that. I was an early leader, so that was kind of cool. I tried to fit in and do sports many times and just never worked out. But around adolescence, it really came to a head. I put on a bunch of weight, and I was kind of an outcast for that, and also just being kind of a nerdy, heavy kid that didn't do sports. There really wasn't a place, there wasn't a niche for kids like that back then. Uh, And it really hit me hard. It was a very emotional thing, and it drove me to move to a different part of the library and look at health books. Like, well, what can I do to figure this out to improve my own health and improve my social standing here and do things a little bit better? So I dove into some health books. Pretty awesome thing. Changed my life in a lot of great ways, and it made me want to be able to give back. And I realized that as a kid, information I found was phenomenally helpful. And if that was the case, how many other people were living in ways that, they weren't as happy as they could have been? And there were simple answers that might have been available for them. So that really drove me to do what I did. And then in medical school, I saw that there was such a big gulf between the conventional views of thyroid disease and then these alternative views that were just emerging, and the disease was really picking up. It was getting more prevalent. And some people were helped by the alternative approaches, but some were harmed. There were side effects. And so from the very beginning, I wanted to figure out, why is this happening? Why is it more common? How can it be treated? How can it be safely treated? And what were the best ways that can effectively naturally resolve it? So that got going in the mid 90s, and I've been running with that since.
Hmm. So you said that you were overweight. Was that just because was it a thyroid issue or was it just an inactive issue?
It was an inactive issue, and I don't know. There was also ways in which I don't know if the seizures were a factor, but yeah, I early on had just very intense food cravings, and between that and the inactivity, it just didn't pair well. So
Mm,
yeah,
mm. So why thyroid? Did you see that there was a gap? Is that why?
I saw there was a huge gap. I remember in about 95, 94, when I was doing clinical care and in rotation still, a couple of patients I saw back to back, one of which was a young gal who was about to be medically discharged out of high school. Like, she couldn't be able to finish high school because she was so functionally unable. Energy was so bad, fibromyalgia was bad. And one doctor, based on some rather loose guidelines, thought that thyroid therapy would help her. And it did. She went on natural thyroid medication. She was able to resume school. It was a phenomenal conversion. And then I saw another patient who, similar setup, a little older, same doctor, same attempt. But this person was hospitalized from cardiac damage from trying natural thyroid therapy. And I'm like, well, shoot, this was a real hit over here and a real miss over here. So there's something to this. And many who were struggling with this went through things like I went through, the weight, the problems like that. But they were already doing a lot of things that should have been enough, but they weren't working. So there was more to it than that. And it wasn't a matter of, just throwing everybody on a lot of meds. There was more nuance to be sorted out.
I think you just called it right there. I think that people don't realize how critically important being balanced in thyroid affects everything. I mean, I had to be there was 5 years where they suppressed my TSH, and I know we're going to get into all the measurements, but it's something that they did for anyone who had thyroid cancer. They wanted to keep that thyroid stimulating hormone as close to zero as possible. And I didn't understand why I had heart palpitations and why I had anxiety and why I was jittery a lot of the time. And I think it's that whole Goldilocks theory where you just want to be just right. Would you agree?
Couldn't agree more. And hormones in general are pretty fascinating things. They're little tiny microscopic chemicals that we make that control other things. Thyroid hormones are unique, that they respond, every cell in the body responds to them. That's not true of any other hormone. And the quantity is insanely diluted, the amounts. Like, if you could take out what the thyroid would make in a day and put it in your hand, you couldn't see it. It's like a tiny fraction of a grain of salt. But if it wasn't there, you couldn't live. You'd be dead in a few weeks. And
Yeah.
if that fraction of a grain of salt was a couple of grains of salt, that would also do you in. So yeah, the balance is so exacting. I did the math one time, and the concentration of thyroid hormones in the bloodstream, it's pretty much if you go to like an Olympic-sized competitive pool and drop in a teaspoon of vanilla extract and stir.
Yeah.
That's about how dilute it is. But yeah, if that teaspoon was missing, you can't even live.
Yeah, yeah, because there was also a time they took me off all my meds. So, like, I mean, this was a trying time, let me tell you. And I know that you would understand it more than anyone or anyone else who's been through it, where they took me off all medications and I had to have that injection, thyrogen. I think it's called
Mhm.
thyrogen. And during that time, I think my TSH climbed to 32. So it's like, I don't even know if I was coming or going half the time for that first year. And then I had to research. So perhaps you can start very, simply, what exactly in the body does the thyroid do? Because people think it's only metabolism.
Yeah, so three big things. That's one of them, metabolism. So that's the gas pedal. It's how quickly you convert food into energy. So if you do that slowly, you're not making food into energy. So weight's an issue. You gain weight more easily, you can't lose it, but you're also not making a lot of energy. So fatigue is a big problem. So yeah, that's the gas pedal, it's metabolism. Then we've got tissue repair. So part of our body is a distinct cluster of cells, and every cell is only with us for a while, and it dies off and new cells take its place. And as long as the repair rate is appropriate to what the die-off rate is, then we're okay. But if the repair rate is not right, then we get hair loss or dry skin or
Mhm.
poor nails or musculoskeletal injuries or bone thinning or various problems like that. So yeah, repair rate. And the other big category is going to be nerve conduction. So how well our brain cells talk to one another and how well our brain talks to our fingers and our feet. So yeah, numbness, tingling, mood changes, brain fog, all big factors. So those are the big three categories. But there's also a lot of ways, apart from the specific roles, that thyroid hormones also interact with other hormones. So
Mhm.
when thyroid levels are not right, other hormones don't work properly either. And we'll talk more about interactions that way. But yeah, there's a lot of ways in which changes in estrogen, changes in stress hormones, they can interact with thyroid levels.
Yeah, we were just touching on that just before. I was telling Dr. Christianson about how when I was after I gave birth to my second child. That's when I started to know things not like they just weren't right. I didn't feel right, but I was not given any testing. I was not, and unfortunately, still to this day, the go-to is TSH only. So, when somebody's encountering all of these symptoms, what tests do you recommend they get from their doctors?
Yeah, the two big questions to answer are whether the thyroid function is off and whether there's thyroid inflammation. And they're separate problems. So far, we've been talking about the function, like if it's making enough hormone or too much, and super important. It's a little more rare that that's off to a degree to where it's the sole cause of symptoms. A more common scenario is that there's an immune attack, there's inflammation with the thyroid, and that can cause all the symptoms regardless of the thyroid levels. So, those are the two main things to look at: how the thyroid is functioning and whether there's inflammation behind it. Specifically for tests, we look at the TSH. That's it, and then the measurable hormones, the T3 and T4, are the main thyroid function tests. They're all important. The TSH is the most sensitive of them. We could talk more in depth about that, but T3, T4, your body keeps them steady as long as possible. Even when things are off, it can often still keep them steady until it can't. And then we think about thyroid inflammation. So there's several measurable thyroid antibodies. And the odds of someone's thyroid like shutting down to where it's clearly causing symptoms are about 1% in an adult population. But the odds of someone having enough thyroid inflammation to cause symptoms are more like about 20, 24%. So it's way more common. And many people, again, their thyroid still works fine, but there's inflammation causing problems. And this is the main thyroid antibodies we measure are thyroid peroxidase and anti-thyroglobulin. Not the only ones, but the most common ones for screening purposes. So those are the two main categories of things to look at if someone suspects this might be a problem. So yeah, thyroid function and thyroid inflammation.
So would you say, because I've also researched a lot of this, and the tie is usually with autoimmune, Graves or Hashimoto's. I read some statistics, perhaps you can correct me if I'm wrong, but something like, I don't know, was it 80% or 90% of hypothyroidism is due to Hashimoto's, which is an autoimmune condition, which doctors can only really diagnose if they check the antibodies, what you mentioned. Does that make sense?
Totally makes sense. And I would pull two things apart. There's diagnosing and there's ruling out. And
Okay.
the numbers are fuzzy. The numbers are very fuzzy. And the reason is because there's not a good way to rule out. So outside the window, there's no wildlife there right now, right? So you could say, oh, there's no deer, there's no bear that come through the yard. Well, there's none right now. You can't see them. That doesn't mean they're not there ever. If you see them, you know they're there. But if you don't see them, you don't know that they're not there ever. So that's diagnosing versus ruling out.
Yeah.
So you can't rule things out by not seeing them. In the case of thyroid autoimmunity, we define it as cellular changes. So the only real rule out is cellular analysis, which is biopsy, which is really not done for screening purposes. So the blood markers show it sometimes, but many people with thyroid autoimmunity have what's called seronegative autoimmunity. Sero meaning blood, meaning their blood tests are negative, but they still have autoimmunity. So that's why there's not hard numbers on exactly how many with hypothyroidism have it from Hashimoto's. Yeah.
Oh, that's so interesting. So just let's just throw out an example. I have all the symptoms. My hair is falling out. I have no energy. I have brain fog. I am gaining weight unexplainably. I'm depressed. I am cold all the time. I may have edema. These are all symptoms I've had, by the way. Uh, so I can rhyme them off really easily. Um, and then I go to get my blood work done. It could show antibodies normal. It could show free T3 normal, free T4 normal. So I guess then what? Like, how do you? I mean, nobody, first of all, here where we are, I don't know how it is in the US, but if your TSH is within this vast range of 0 point around 4.5 or 5 to 5.0 with some labs, they're not even going to test further than that. And you may feel I know I feel horrible if I go past 2 in my TSH. So what do you do?
Yeah, you check the antibodies. That's the next step, and see if that's relevant. And if they're not positive, and someone has a strong family history, and if someone has any localized symptoms like swelling or possible nodules, then an ultrasound is the next step. There are times the antibodies are negative, but the ultrasound can show that there's autoimmunity present.
It's funny. A lot of people don't even know this, but the findings for my situation were very incidental. It was done because I, for the first time at 41, had a migraine with aura. I had a substitute doctor who was wonderful back then. And she's like, well, that's not normal. Let's do some investigative tests. She's amazing. And she had the carotid artery ultrasound. They're like, oh, arteries look great, but we found 5 nodules and some of them look kind of big. And that was what set the pace for everything to start happening. Then I had the fine needle biopsy, just like what you were saying. And it's kind of how it began, but it was very incidental. And I think, do you even know what are the stats of individuals with undiagnosed thyroid disease? I read something somewhere. It's pretty huge, right?
All different kinds, but nodules specifically, the stats there, the odds of having nodules are pretty much, if you take your age and put a percent number on the end of that, that's pretty much your odds of having thyroid nodules. So, yeah, you were 40 at the time, you had about a 40% chance of them being present. And each nodule has about a 3 to 7% chance of harboring thyroid cancer. So they're very common.
Wow. So but you said each nodule has only 3%, 3 to what? 5? 3 to 7 for it to be actually malignant.
Mm-hmm.
Oh, interesting. So okay, what would you do? You work very differently though, because you're in integrative medicine. I guess what I'm going to say is if something's off, you need to find the right doctor who can help you do some of the detective work.
It is generalization. Thyroid disease can be structural, it can be functional, it can be inflammatory. We talked a little bit about inflammatory and functional, like the antibodies, the TSH64, structural, that's the cancer and the nodules. And simplification in terms of viable, helpful lifestyle treatments, natural medicine, integrated medicine, I would argue there's really not much there for structural disease. There's really not good. The main thing for structural disease is having to change the structure, and that's often surgery. So yeah, in those cases, that there really are no effective natural solutions besides what conventional medicine offers for structural disease, but a world of difference then for managing afterwards, for the function, for the inflammation. But yeah, for the structural problems, the overall approach in conventional care are appropriate.
Let me ask you this question because I've often pondered this. Because I had 5 nodules, and a lot of people say that they can shrink their nodules. So, for example, the malignancy was only on one side, and they did tell me, you can take only half of the gland out, but 80%, this is way back, 80% of our patients come back and have to have the other half removed. This was a stat that they gave me back in 2011. 2011. Can you shrink nodules?
In many cases, nodules can shrink. There have been some clinical trials on that. Diet changes can affect that. If weight loss is needed, weight loss can affect that for some people. And then also some nutraceuticals have been shown to help. Now, that's shrinking overall size. If a nodule already harbors some cancer, that's not the same thing as making
Right.
cancer go away. But that's changing how risky a non-cancerous nodule is.
Exactly. So only 1 of 5 of the nodules that I had was malignant when they did the final pathology on the I donated my thyroid to science. I'm like, take it, do whatever you need to do with it. So only 1 of 5 were actually malignant. Maybe it's a good time to get into nutrients that could support thyroid health and maybe help to shrink nodules. And why do we get nodules in the first place?
Yeah, so this is a growth problem. So the cells don't grow properly. You grow some cells that are ones that the body doesn't really need. They're not well regulated. I talked about how we're always growing new cells. It's kind of fast in the thyroid gland. Each cell only makes it for a few months. There's a high rate of turnover, and a lot of things correlate with how the growth occurs and when to stop. And in many cases, random junk forms. Some of that random junk becomes cancerous. So the nodules are the random junk.
Now, would you say that the thyroid is especially sensitive to toxins?
Yeah, so the interesting thing is that nutrients work in your body kind of like soup, like if your blood is soup, so you've got however much salt in the soup, that's how much salt there is in the carrots when you drop carrots in the soup, right? And
Yeah.
that's how much salt ends up in the onions, right? Assuming you didn't salt these things separately, right? So that's how nutrients work in your body. If the carrots are your liver and the onions are your heart, whatever's in the soup is what is in them. But your thyroid's not like that. Your thyroid's got its whole own compartment and its whole own pump. It's pulling in one nutrient and concentrating it. And in doing so, other things can get concentrated as well. So in some cases, the thyroid is more sensitized to environmental toxicants because it pulls things in at higher concentrations than other parts of your body do.
Yeah, I did a whole cleanup back then. I guess you could say I was a little bit of a holistic mom even before all of this because when my daughter was a newborn, she had eczema. And so back then though, it was very difficult to find. And this is what I always say to people, baby steps in terms of cleaning up the toxins in your home. You don't have to go and throw everything out. It's just like when you run out, replace it with something that's a better choice, that's not as toxic. That goes for cleaning all of the things that I clean my house with, the things I wash my dishes with, my clothes with. I'm just very cognizant of this. But then there's chlorine, and I have a pool. So, what are your thoughts on chlorine and fluoride for thyroid?
So that's interesting. So the thing your thyroid pumps in is primarily iodine. And there's some compounds that are chemically related to iodine. They're called halogens or halides. And there's a lot of we can talk quite a bit about this topic, but there's a lot of thoughts out there, a lot of things that are talked about that are plausible, but actually have already been tested and just shown not to be relevant. So chlorine is a halide and fluoride is a halide. And fluoride, for example, if you consume more than about 5-10 milligrams a day, there are higher rates of hypothyroidism. And that occurs in some areas that have massive amounts of fluoride geologically in untreated water. So rural China, some areas that the rock structures have a ton of fluoride in well water and no one treats it. That's a problem. But below that, fluoride has pretty minimal effects. This has been studied in a lot of big populations. So there's a dose threshold. Chloride, chlorine, also a halide, but it also no real specific effects upon the thyroid. There's a point at where it can be a lot of it orally can be a factor for stomach cancer risk. Inhaling it can be a factor for lungs or asthma, but it really doesn't do anything to the thyroid, good or bad.
Okay, that's so interesting because I was always taught that halogens, if you don't take in enough of the nutrient that it actually needs, your thyroid, meaning your thyroid, which is iodine, it's almost like it takes up a receptor or it takes up a spot if you're not eating enough of the nutrients, because it's like the thyroid needs iodine to function well, but the right amount of iodine. So if you're swimming and swallowing globs of chlorine, you're saying that it wouldn't affect thyroid function if you're not eating an iodine rich diet. That's also.
Regardless of that, the receptor is called the sodium iodide symporter.
Okay.
And it's not the sodium halide symporter, it's the sodium iodide symporter. It doesn't respond to iodine, it only responds to iodide, and it doesn't respond to halides. It's specific to iodide. And it's a plausible idea that maybe these other things would get studied, just don't. That's just not how the receptor works. This has been studied.
That is so good to know because I have always believed otherwise. I've always believed that. So that's good. I'm glad you clarified that. Now, iodine is a tricky one though, because you also don't want to overdo iodine either. Do you want to get into that?
For sure. So we can talk about causes, contributors, comorbidities. They're all sometimes jump together, but they're all different. So causes of thyroid disease, a cause is something that can make a disease happen regardless of other factors. So all by itself, it can make it occur. And causative factors, there's only a couple. We've really got age, gender, genetics, and iodine status. Those are the only things that can do it all on their own with no other factors. Now there's a million contributors. So if they have those little things at the fairs where they're pushing these stacks of coins, and maybe if you put your coin in, they're all going to go over the edge, and you get a bunch of coins. There's little games like that. So yeah, the other things are kind of like more coins that go in. If it's about to fall, maybe this other thing will make it fall. If it's already set up, they won't make it happen all by themselves. So yeah, there's about 300-400 environmental toxicants that are contributors. There's no short list of other health problems that either contribute or are comorbid that go along with thyroid disease. But clearly causal, it's just those few. Now the weird thing is that it's so highly genetic. If someone's a twin, identical twin that has thyroid disease, their other twins got like an 80% chance of getting it. And then siblings a little lower and so on. But the genes that are involved are all genes of iodine regulation. So that's the genetic link, is how people regulate iodine. Now, nutrients, we can think about three different amounts. There's a requirement, there's a toxicology, and then there's a tolerance. So there's how much you need before you're deficient. There's how much you can take before it damages your organs. And there's how much you can take before it just doesn't work as well.
Mm-hmm.
So that's not the same as being toxic. That's just not being as effective. And with iodine, our requirement is pretty much based on our body weight. There's not a lot of variation on that from person to person other than body weight. Our toxicology is pretty much body weight and then kidney function. But our tolerance is incredibly genetic. So when someone has a family history of iodine, they may have a different tolerance. And there's basically two main gene variations in humans. One group of gene variations adapted to coastal environments. Their diets had a lot of shellfish, fish, probably a lot of sea vegetables. And the other variation was well adapted to inland environments. They didn't have much of that.
Mm-hmm.
So the coastal genetics can dump extra iodine, no problem. The inland genetics can use every speck of iodine, but they can't tolerate a lot of it. So People that end up with inland genetics in the modern world sometimes get exposed to amounts that are just unsafe for them personally and can trigger thyroid disease.
Right. It's if you take too much of it, it can exacerbate the issues, right? Like
And
it.
too much is not the same for all people. So too much is different
Right.
based on your genetic risk.
So, how is one to know what your tolerance is?
Well, it's tricky. So ultimately, it's just knowing if you've got a strong family history or a personal history, then you've got a poor tolerance. We know about a dozen and a half relevant genes, but gene status is not always the same as gene activity. So you can test and measure and look at the genes, but ultimately, if it's showing up in your family or if you had issues yourself, you're someone with that narrower tolerance.
What's a good way to test iodine?
Well, there's really not.
I knew you were going to say that.
Yeah, unfortunately. So there's a lot of nutrients like iron or vitamin D to where if you get into it, you can see, yeah, how much you're taking in. Iodine's not one of those. And the amounts of it, the problem is that the amounts of it in your thyroid, because of the pump, do not reflect the amounts in your blood or your urine because you regulate it so closely inside there that you can't measure the amounts outside your thyroid and say, hey, what your intake is. Now, there is a place for lowering iodine. And when someone has deliberately lowered it, then testing can be useful to see if you've gotten to a target or not.
Mm, yeah, because there's different ways. Like blood is not good, but urine might be a little bit better. Does that make sense?
Yeah,
Or
blood tests correlate with the iodine toxicology, not the iodine tolerance. Once your
right.
kidneys can't filter iodine, it builds up in the blood. Before then, there's no relationship between your blood and your thyroid levels. Now, urinary levels, they vary so much from one measurement to the next that you have to test over hundreds of times to be within like an 85% accuracy.
Mm,
So they're actually really good tools for a population. If you want to know if one group of people in one part of Canada, if they're overall sufficient or deficient or excess, you can do a urine test for 500 or more people, and you can answer that question. But you can't ask the question for any of those individuals, just for that group. Uh, and then there's 24-hour urine tests, which don't really change it all that much. But if someone already has embarked upon reducing iodine, then urinary iodine to creatinine ratios, they can see if they're at a therapeutic level or not.
mm.
And so, someone, for example, if they're reducing iodine, they may not have seen it help. They can then check and see if it didn't help because it's not going to work or because they're not on target. They haven't given it enough time or there's some sources that they've been missing out on.
So it's really hard to know if you're getting enough in your diet, really, for you.
Really not, no. So the assumption that many have is that a deficiency is as common as an excess.
Okay.
And there were times historically where that was true. Those times have come and gone. So we've had 7 documented cases of iodine deficiency in North America since 1980. So it happens, but the odds are pretty much against it.
So you're saying that the majority of people have enough iodine in their diets?
Yes,
Oh, interesting.
yes,
Okay, let me ask you this question. Here's another
sure.
question for you. At the exact same time that I was diagnosed with thyroid cancer, I also had a breast tumor. And I do know that iodine is an important nutrient, not just for the thyroid, but also for breast health. So
Yes, and we can talk about that.
okay, yeah, yeah. Let's get into it. Like, is that a coincidence? A coincidence that the two were connected?
One more step. So there's iodine is the most studied nutrient on the planet, bar none. Like vitamin C, forget about it. No, iodine is more studied than any other nutrient by far. And somewhere around 98, 97, the dear man who's passed away, I spent a lot of time talking to him, I read all of his work. He was a gynecologist, and he saw studies showing that women with fibrocystic breast disease, really
Yeah,
painful, they could take high dose iodine and lower their pain. And not having a big background in nutrition, he confused how a nutrient could, the nutrients can be drugs or nutrients. So niacin, for example, a megadose of niacin can lower cholesterol for a lot of people. That doesn't mean that high cholesterol is a niacin deficiency. So
right.
yeah, it can work as a nutrient or it can work as a drug. Another example with iodine, if I went and snagged my arm on a thorn, I could get infected. And there's a fair chance that iodine could stop that infection. That infection wouldn't be an iodine deficiency, right?
Right.
So he didn't really make that distinction. And he assumed that these women with fibrocystic breast disease were iodine deficient, and that's why it helped. And he then went on to make very elaborate arguments about this whole revolutionary world about iodine. Sadly, he didn't spend much time looking at the existing literature. And his discussions have influenced a lot of the common beliefs in natural medicine, including the whole iodine breast risk. So here's what we know about this stuff. So the breast tissue, like other parts of the body, do also concentrate iodine in some circumstances. I was saying before how the thyroid needs more than we get in the soup. It's got to concentrate it or regulate it because sometimes the soup has too much, right?
Right.
Now, breast tissue, the amount in the blood may not be enough for breast milk for a baby, or it could be too much. So the breast tissue also has a regulator. Now, in a non-lactating woman, that regulator is pretty much turned off. But there are times in which that regulator is not working properly. And iodine, it's a generator of free radicals. So think about like bleach or hydrogen peroxide. They make free radicals. That's how they sanitize things. And iodine does that too. So when that doesn't work right, too many free radicals form inside the breast tissue. And a mild excess can cause fibrocystic breast disease. A severe excess is correlated with many types of breast cancer. But here's the big paradox. There's a lot of ways in which too much iodine is harmful in the long term. And in the short term, too much can seem like it's helping. And the reason why is it just shuts off the pump. So if you're getting a little bit too much iodine in your breast tissue and you consume a lot of iodine, you shut off that pump for a few months and things stop hurting. It wasn't because you needed more iodine, you just shut off the pump for a little while.
That's fascinating because back then, a natural health practitioner I was working with this way back, I was instructed to paint iodine in the area where I was having pain. It ended up being a benign tumor that I had, a fibroadenoma, what you were saying. So, and it did help. It helped with the pain.
It would, yeah. And so then others have speculated, well, wait a minute, the Japanese women, they have less breast cancer. They consume more iodine. There must be some connection.
Yeah.
Well, they have less breast cancer. There's a lot of reasons for that. And this is more historical. It's not as much current, but historical Japanese women, lower body weight, lower saturated fat intake, more phytonutrient intake, lots of green tea. But when you take Japanese women and you separate them out for their iodine intake, it's a risk factor. So the more iodine they're consuming and excreting, the greater their risk is of breast cancer. And that shows up in other populations as well.
So really, you just want to always be kind of down the middle. You do not want to take excess iodine. You need to be cognizant and be careful of that.
In terms of numbers, people that are not prone to thyroid disease, they can safely occasionally consume about 1,100 micrograms of iodine for a few days every now and then. But those prone to thyroid disease, their window is probably about like 50 to 200 micrograms. And the more they get outside that window, and the thing is, pretty much any modern diet, no matter how much you're limiting iodine, you really can hardly get below 50 micrograms. The one exception is if all you're eating is raw cruciferous vegetables, that you can do it that way. But I mean all you're eating, like no exaggeration. So yeah, then you can get under. Otherwise, you won't get under that. But it's easy to get above 200. And if you're genetically prone to thyroid disease, that's where problems can start. The cool part is that so many kinds of thyroid disease, we used to think that once they were started, horses out of the barn, they were going to do their thing. But they've done some studies now on individuals who are deliberately going lower on iodine, like lower than 100 micrograms for 3, 6, 9 months. And a really high percent of people can reverse many kinds of thyroid disease from that.
Oh, that's interesting. Very interesting. Let's get into selenium because selenium's another one of the nutrients that's very intricately connected to thyroid health.
Sure.
And that's another one that can be overdone as well, right?
Yeah, so there's a thing called selenosis, and selenium can be toxic. That's somewhere above 400 micrograms in supplements. Kind of curious thing, but most food-based sources of selenium don't really bioaccumulate. So don't have that danger. Selenium, what it does is it affects deiodinase enzymes. Those are iodine regulating enzymes. So whatever someone's iodine tolerance is, if they're low in selenium, that tolerance is even narrower. But that doesn't scale forever. So you can't take extra selenium and tolerate all amounts of iodine. But selenium's main role is just helping the body regulate iodine.
Okay. And here's a question about selenium, because I've always eaten 2 Brazil nuts or so every day. And you're saying that if you're eating more selenium, it doesn't bioaccumulate. But if you're taking selenium, it can.
Yep.
So if somebody knows that they have thyroid disease, like me, and you know that you have adult children who eat a horrible diet, is it safe for them to take can you tell I'm talking about myself? Is it safe for them to take selenium once in a blue moon? If they don't eat Brazil nuts, they don't.
100 micrograms, it's a safe thing.
And that's
And I,
once in a blue moon. Like, it's not all the time, every day. It's just,
daily intakes of 1 to 200 micrograms are reasonable, and one doesn't have to stop or rotate or pause with it. And
oh no. But even though but what you're saying is if they're getting it in their food, it's not bioaccumulating anyway.
no, it's useful. It's good for you, but it doesn't become excessive, the food sources.
Right.
There's one rare exception, which is called paradise nuts, which we don't commonly have in North America, but they have a different kind of selenium that does bioaccumulate. But Brazil nuts and other high food sources, there was a study that was done, and it was a pretty weird study. If someone had asked me if the study should proceed, I would have said no. But now they did it, we got this data, but they took kids that were about 5 years of age, somewhat malnourished. Average body weight was like 35 pounds. And in their school, they were getting some school lunches. So one group of these kids, they fortified their food with massive amounts of Brazil nuts. It ended up being about like 20% of their calories. It was like for you or I, for like an adult dosage, it would be about like 30 to 36 Brazil nuts per day, as far
Wow.
as how much they consumed. Now, they measured selenium in their nails, their hair, their blood, their urine. And some of these things show selenium excretion, and some show selenium bioaccumulation. So you can differentiate that. And these kids were excreting more selenium, no doubt about that. But they had no signs of bioaccumulation. And
Oh.
all the ways in which selenium works in the body, such as glutathione activity or maturation index or cognitive development, these kids were healthier than their peers. They were doing great. But they were excreting a lot of it, but they weren't getting toxicology from it.
Okay. Okay.
It's a pretty extreme test.
Yeah, that does sound extreme for kids, right?
Right. Right.
Yeah,
If there was ever a time in which the food sources would have gone wrong, it would have gone wrong then for those kids.
exactly. Okay. Vitamin D is also really important. What are your thoughts on low vitamin D? Does that have any impact on the thyroid? How does that impact the thyroid?
I want to back up one step and I'll come back to that. But
Sure.
you mentioned about causes. So there's things that cause disease and contribute. And so we're on to contributors now.
Yeah.
Iodine was the one causal thing. Another distinction is that within causes, some causes are reversible and some causes are not. So, like our genetics or our gender, those are irreversible causes. But the only single thing that's been ever shown to reverse thyroid disease is iodine regulation. We could talk all day long about diets, nutrients, and low vitamin D can raise someone's risk of getting it if they're already prone to it. But there's never been clinical trials showing that that reverses the existing disease.
Mm.
That's only iodine regulation. So we can come back to that if you like. But yeah, just to be clear, we're now outside of causes and we're now well outside of reversible causes. So vitamin D is interesting. There's a range in which those who are in that range have lower rates of autoimmunity in general. The other weird thing about vitamin D is that it is a negative acute phase reactant. That's a big mouthful. What it means is that when you're sick, your vitamin D levels go down. And so there's a lot of ways in which vitamin D is low in unhealthy people. That's not causal, it's probably adaptive. So many sick people, their vitamin D is pulled out of their bloodstream and used in tissues in various ways.
Mm.
And this is why there's so many studies correlating low vitamin D with illness. But when they do an interventional study to see if adding vitamin D reverses the illness, the studies fail. And that's because it's a negative acute phase reactant. It didn't cause someone to get sick. Being sick was the cause of vitamin D being low in most cases, rather than vice versa.
Right.
Having said that, it's better to be at an appropriate level. And one more wrinkle is that more is not better. A lot of studies about vitamin D were first done in Europe, and many were using metric blood levels. which a lot of health experts failed to translate into American blood levels. So many talk about having these really high targets, and I say, well, no, wait, that was right for metric. We have standard units. So when we convert to American units, the lowest rate of mortality and autoimmune disease risk is about 35 to 55 nanograms per mil. And many talk about higher numbers just from not converting that.
Very interesting.
Because nanomoles per liter, the metric units, that's about like 80 to 120. But so many health experts say, yeah, that's your target. Well, that is, but not for the units we have in our blood tests.
Right. And Canada is like Europe. I think we have the same, because we follow the metric system in Canada.
I don't know if you do for the blood test or vitamin D or not.
It's so complicated because I have to do a lot of converting, and I look very closely at that as well because there's not really a lot of consistency. I don't know when it comes to blood work.
Right.
So we've talked. Are there any other nutrients you want to talk about as it relates to the thyroid?
There's tons of contributors, but honestly, once you get past the relevance of iodine, so
Yeah.
one study, for example, took people who had hypothyroidism, and there's degrees of hypothyroidism.
Yes.
Their TSH was more than 14, their T4 was below range, they had signs of Hashimoto's present, they were sick, and they'd been there for about 4 years on average. It wasn't like a one-time fluke reading. And the only intervention they had them do is try to get their iodine below 100 micrograms per day. Now, in 3 months, 78.3% of people fully reversed their thyroid disease. They had perfectly normal thyroid function. That was all they did. And of the remaining 22% who didn't get better, one group of them had TSH scores in the 50 to 200 range, and they weren't normal. They were heading that way. They were down by half or more. And another group simply didn't get to the iodine target. They weren't following the diet. So over 95% of those who were following the guidelines either fully reversed their disease or they were heading that way. And nothing has ever been shown besides that to actually reverse thyroid disease.
So you're making a very clear argument that we really need to understand our iodine intake.
So step 1, step 2, step 3, step 4, step 5 are getting your iodine dialed in.
Yeah.
Nothing else matters.
Wow.
Nothing else helps in the same way.
Okay, so then but I'm always going to go back. Like, does that mean everybody has to test their genetics? Like, how are we to know?
If someone has thyroid disease or has a strong family history of it, they likely have the genetics that make them less tolerant. And there's not a risk that the targeting levels in terms of the ranges for helping the thyroid are not levels that cause deficiency. So it's not that someone has to do something risky that would be bad for them otherwise. It's a safe thing for someone to do if they have or suspect thyroid disease.
Okay, can we move on to adrenals, the adrenals, and how that is tied to the thyroid? Because as you said earlier, the thyroid function can be affected by other things going on, such as stress.
Mhm.
So how are the adrenals, how do they affect thyroid function?
Yeah, so the adrenals, they can be diseased and they can be dysfunctional. And diseased means that they quit or that they're out of control. Those things are kind of rare. The most common diagnoses are Addison's disease or Cushing's syndrome. This is a few people per million. We can set that aside for now.
Mm-hmm.
But the dysfunction is quite common. Now, the adrenals are circadian hormones, which means that they work differently at different times of day. We make a lot of cortisol when we wake up and we shut it off as the day goes along. That's important by itself, but it's kind of like the conductor of the band for many of the rest of our body's pathways, which are also circadian. And in a lot of cases, we don't time it properly. Chronic stressors, inconsistent daily habits, a lot of ways in which modern life takes us away from the cycles of nature. We can get that thing timing, that we can get that thrown off. And that then makes our bodies less able to control inflammation and also less able to adjust how hormones enter our cell membranes, including thyroid hormones.
Mm-hmm. New moms, right?
Yes, for sure.
I just remember during that time, I didn't sleep for about 8 months, and I had a traveling husband who traveled almost weekly. So it wasn't, and a toddler and a baby. So, new moms, if you're listening, I know most of the people that listen to my podcast are a little bit older, but you may have daughters that are going to be new moms. So it's good to educate in this area that, we really need to take care of ourselves and take care of ourselves during all times and phases of our lives.
Well, new moms, there's a double whammy. We can come back to this topic, but you've got this big change in the stress response, this big change in your sleep patterns, this change in your stress load, but also a big change in your body's circulating hormones. So there's this
Yes.
rapid decline of estrogen and progesterone. And I mentioned before how thyroid interacts with other hormones. So we can come back to that. But yeah, new moms get a double whammy.
Yeah, so you just said it right there. It's like you have this you have so many hormones raging through your body when you're pregnant. Then you give birth and things change. This is why I can only surmise because I was never diagnosed with anything after I had my second, but I can say I'm pretty sure I had a lot of the symptoms of postpartum thyroiditis, which never were addressed, never known, and then many years later, nodules, all kinds of issues. But you mentioned the decline in hormones. That also happens at menopause, and we hear a lot of women having thyroid issues at menopause. So, how is the thyroid connected to estrogen, progesterone, maybe testosterone? I don't know. Tell me.
Estrogen, very much so, progesterone, a little bit, testosterone, not as much. But the connection is really a protein called thyroid binding globulin.
Yeah.
So, thyroid hormones are regulated by, we control how much comes out of the thyroid. We also control how they circulate throughout the body. And there's dozens of mechanisms that are involved with that. But a big one is a binding protein that makes them less active. Now, that binding protein is inversely tied to estrogen status. So, when there's a lot of estrogen, there's less binding, and then also vice versa. So when estrogen levels change, the body needs to shift its binding proteins, but they can't adapt quite as quickly. So suddenly the amount of hormone in circulation is not what your body needs if there's a big shift in estrogen. So yeah, moving out of pregnancy is a dramatic shift, starting or stopping hormone replacement, entering into perimenopause, entering into menopause. We know that autoimmune thyroid disease, once a woman enters perimenopause, her risks go up fivefold just with that transition alone.
Hmm. Now, for anybody who's listening, if it's bound, that means it can't actually do anything in the body, correct?
Yeah, yeah.
And you also mentioned even taking HRT can affect thyroid in more of a positive way, I would say, right? If it's the right dosage of HRT.
Well, binding again. So yeah, you're raising estrogen and you're changing thyroid binding globulin. So most women that go on some version of a systemic, like not a vaginal estrogen, but a whole body estrogen, most who need thyroid replacement need more thyroid replacement. And then vice versa. When a woman discontinues a whole body estrogen, she usually needs less hormone replacement. Also, we look at just the body mass or thyroid requirements are different from women for men until women are menopausal and not on therapy. And that's why. So estrogen has a inhibiting effect on the activity of thyroid hormone.
Okay, I need to say this again just to make sure my brain gets it. So, if my estrogen tanks at menopause, then my binding globulin, hormone binding globulin will go up, right?
No,
It'll go down. Explain that. I just want to say it in a different way. So, for any woman who is going through menopause and your estrogen tanks, I'm going to let you finish that.
So that change alone is not as abrupt. The change in the perimenopause, the change after pregnancy, or the change of starting or stopping replacement therapy is more abrupt. So just the change itself can disrupt the thyroid balance. And in general, more estrogen in the body means more thyroid is required.
Oh, okay. This is very interesting because,
If I had a twin sister who was my exact same body size, and she was, well, I'm too old, but if she were of menstruating years, and I was at that same age, she would, and we both had our thyroids taken out, she would need a higher dose than I would.
Okay. Okay. And because I know too much estrogen can affect thyroid function, too little estrogen can affect thyroid function. And again, we're kind of back to that whole Goldilocks theory of you want just
The
right.
changes can affect it, even if the changes are moving to the right amount. That can affect it as well.
It's just the shift in and of itself that can make a change in how your thyroid is functioning.
You have too much, too little, or a radical change.
Okay. And what about if someone doesn't have a thyroid and their entire function relies on medication? And by not having a thyroid, that can mean actually like physically removed, like me, or even ablated, right? 'Cause some people just have their thyroid completely ablated, maybe not physically removed out of their body, but doesn't ablation completely just kind of kill the function?
Generally, and also someone's medication dose. If their medication is pretty much what their physiologic requirement could be, then their thyroid is not really functioning. And they can be considered almost athyrotic as well.
Really? So if somebody takes medication when they don't need it, your thyroid will.
In that moment, yes. And if that's
Oh,
long term, that can cause the thyroid to atrophy.
that is interesting. Okay. So,
Simple math. If someone's dose, you can look at their dose, look at their body size, and say, "Yep, that's all you would need." And if their levels are stable, their thyroid's not doing anything. And vice versa, if someone's levels are stable and their dose is half of what they need, you can say, "Oh yeah, well you're making about half of that by yourself."
so if your entire function is reliant on medication, how, because I know for myself going through menopause, even though my medication is the same, I've had to change doses numerous times during this time of perimenopause and early stages or late stages of perimenopause and sorry, late stages of perimenopause. Technically, if you're going to look at the technical term, I'm still in that. Or you could say early menopause, however you want to say it. But for me, things are kind of changing and my TSH is changing and my I've noticed my free T3 changing and my free T4 changing. And is this because my estrogen is kind of going like this?
Can be. There's also a lot of ways in which they change normally. So, thyroid blood tests, if you do them under the exact same circumstances, you won't get the same results. They've got a certain amount of fudge factor you can't escape. So, that's one big thing to be aware of. The other thing is that they're, how you time your thyroid blood test can give you totally different results. So, like morning versus
Hmm.
afternoon, fasting versus non fasting. If a woman's menstruating, which part of her cycle she's in, many supplements can affect this as well. How it's timed relative to your medications. All those things, if they're different, will give you very different results.
Huh. It's
Times of year can also cause variations. And what you're saying is real. There are definitely ways in which you can legitimately need more or less. But putting that aside, all those other things can also make your test levels go up and down.
yeah. I mean, it's a pretty complex little organ, I would say, just because of my experience with it. Now, what, okay, we talked about high estrogen, low estrogen. How does one pinpoint why they're gaining weight when all their levels look perfect?
Sure. So there's weight, there's body composition, and thyroid function is a big part of all of that. There have been clinical trials showing that degrees of having too much or too little can both be problems for people. And
Mhm.
surprisingly, being a little bit above target is a more common driver for weight gain than being a little bit below target overall. Now, being way below target clearly is a driver, and being way, 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 way above target often causes muscle and bone loss. But yeah, if levels are not right in some way, then it can be a problem either way.
Because the one thing I will say, like I'm a smaller woman. I'm 5'2", and I've always been very, very tiny. But since I've had thyroid issues, this is probably from, even the year before, around that time that I really noticed a change. Since I have my thyroid out, I've had a variance of 25 pounds up and down. And as a person who really looks at body composition, I mean, I worked with a personal trainer for 6 years. I am a very active person. I eat well, and still, it's something that I'm always cognizant of. That's why I became a metabolic balance coach, because I found that's the only thing that stabilized my weight in whatever, 12, 13 years.
One more factor to think about is that going back to iodine again. So I mentioned briefly about how it can be a factor with autoimmune thyroid disease. So the free radicals it forms, the proteins in the thyroid peroxidase and thyroglobulin. Thyroid peroxidase is the protein that is the enzyme that activates iodine, and thyroglobulin is a protein that stores iodine. So when the amounts there are wrong, the body attacks those structures. That's the iodine connection to autoimmunity. And there's also a connection between thyroid hormone response. There's a thing called the Wolff-Chaikoff effect, and it's super simple. So I mentioned before how that pump is a pump and a gate. So you get the right amounts in and you block it when there's too much. When there's too much, you block it. And that's true for the iodine coming into your thyroid, but that's also true for the thyroid hormones entering your cells. So when you're above target for your iodine requirements, your body resists the effects of thyroid hormones. The way you control the circulation and the activation of thyroid hormones is by deiodinase enzymes. And if they're above saturation, they can't do all the fine tuning between the T4, the T3, the T2, and so many other Ts as well. And the other big wrinkle is that thyroid meds contain a fair amount of iodine. So in someone who's lacking a thyroid and needs medication, if they're not at a healthy range of iodine, their body will fight the effects of that medication.
Mm. So it's just, and how does glucose come into play with all this? Because I did read some research that individuals who are hypothyroid tend to have issues with insulin sensitivity.
Sure. Yeah, this is in the comorbidities. So yeah, there's causes, there's correlations, and there's comorbidities.
Yeah.
And that's one of many. So yeah, type 2 diabetes, fatty liver disease, even type 1 diabetes. These things are at greater risk for those with thyroid disease.
What are some more comorbidities? Because I've actually been doing a little bit of research just even on longevity and thyroid disease. And it was so interesting. I just started doing this. I'm sure you probably already know this, but they're saying that when you're a little bit hypothyroid, you can actually live longer.
Yep. The further you get past mid 60s, the more relevant that becomes.
Yeah.
Your body's metabolism changes. And yeah, your targets for thyroid levels completely change, definitely.
I know. And then there was all these things. But see, I'm like, I need to be in my sweet spot. And the reason is at least, well, I'm 54. I'm not 60 yet, but
Okay.
I need to be in my sweet spot because I think that would affect my longevity. If I'm not in my sweet spot and I don't have the energy to move my body and I don't have the ability to exercise and do the things that I love to do, that's going to
Your
felt.
sweet spot may change over the years. That happens.
So my sweet spot, because according to this research, it's saying that my sweet spot will not be, because normally I'm around, 1 or even 0.75 TSH, my sweet spot may go up, which is closer to hypothyroid for those of you who are listening.
Yeah, that's quite common.
Interesting. Now, I wonder why that is, though.
Yeah, your body's metabolism changes in a lot of ways. Your body's your overall amount of growth hormone levels is different. Your androgen estrogen ratios are different. So your whole hormonal balance changes. Everything changes with age. All of our hormonal balances do.
Yeah, but I want to be optimized always in all my hormones.
And in a lot of cases, optimized for 65 and 70 is not optimized for 50. We're different as we age.
Yes.
Change in many ways that are actually adaptive and helpful.
Do you think that hormone replacement therapy helps a woman who has thyroid disease
Helps meaning what exactly?
feel better? Feel better. And really, because I'm thinking when I look at all the symptoms of thyroid disease, a lot of them can really cross-reference to menopausal symptoms as well.
Sure.
Like if I look at, when I was hyperthyroid, I would be overheated and I would feel like I'm having hot flushes. Well, that's also a symptom of menopause, right? So
Mhm.
I'm just saying it can get a little hazy and confusing for a woman who has thyroid disease going through menopause.
The cool thing is that it's very, very hazy because a lot of the information that's out there is speculative. A lot of information is this hormone does this thing, therefore, if we give it, we'll do more of that, or therefore this could do something. But we can speculate both sides of any argument in medicine because there's so much complexity of biochemistry. So over the years, I always am aware of mechanisms and arguments like that, but I put so little weight on them. I put a lot of weight on what actually happens to people. High quality human placebo controlled studies. What really happened to people in the real world when they did that? It might not be what you speculate, and that's the once you focus more in that way, things become a lot clearer, a lot simpler. We've got and there's a lot of questions that we don't have perfect answers for. We don't always have the studies we'd like to have, but other things we have good answers for, then there's good clarity. So hormone replacement therapy lowers hot flashes and night sweats for 80% of women by about three quarters. So most it does lower them quite a bit. And the risks of it are rather low for most women within a certain age range.
Yeah.
The risks aren't zero, but there's a lot of ways in which a decline in estrogen does correlate with aging and does correlate with many negative symptoms of aging. But it's an assumption to say that therefore giving estrogen stops those problems. We can only say that if we see that happen to women because taking a hormone is not the same as making a hormone.
Yeah.
It's the same chemical. It's not the same effect on your body, and your body does it by itself. So when we look at the larger studies, even with natural hormones, there's not a strong argument that we stop aging or that we reverse a lot of health problems. We do control menopausal symptoms, and that's totally a valid reason. The risks are not zero, but they're not huge. But yeah, doing it for health purposes, there's not good data for supporting that.
Mm. Very interesting. So, where does I guess we can get into the best options, or do you believe that every patient should have a customized approach to medications? Like, what are your thoughts on T4 only?
Sure, sure. Yeah, so in a moment ago, we're talking about estrogen replacement, and now we
Yeah.
talk about natural and synthetic. And in that context, natural means the same molecule your body makes, and synthetic means a different molecule. In thyroid medicines, we don't use the same nomenclature. We use a very different requirement. Natural and synthetic means we squeezed it out of a pig or we made it in a laboratory.
Yeah. Yeah.
Estrogen, they're all made in laboratories. Some have the same molecule and some don't, but we call yeah, so it's different criteria.
Yes.
So all thyroid medications are natural based upon the criteria that works for estrogen. But some are from animals, and that's valid. And many do well on those types. The natural thyroid gives as stable blood levels as other types do, as T4 only does. And there's strong evidence that many people do better on combination therapy, whether that's T4 plus T3 or some combination that includes natural thyroid. Many do better on that. There's many that do fine on T4 only. They're not the ones that seek out someone like myself or listen to your podcast because they're off doing other things.
Yes.
They exist, but there's a big chunk of people that are not like that, and there's a large movement now in endocrinology that's recognizing that more than ever before.
Yeah, that you're gonna laugh at me that this is back when I had my thyroid removed. So I had one of the best endocrinologists in Canada. He was at Toronto's Mount Sinai Hospital. He's since passed, but I really liked him. And I was doing my research. I had a lot of issues. And remember how you said one one issue, I can't remember exactly how you put it, but the body can slow down repair. And I had a lot of issues with things going, we won't get into it, but things were not right. And I did my research. I said, you know what, doctor, I'm really needing you to give me a little bit of T3. And he looked at me and he looked at me like I had four eyes, like, what? Like none of my patients, because this is back in 2011. And I think things are starting to slowly change, but he did. And that was actually when I saw a fantastic improvement. And I've been on that since. Would you say that people who don't do well on T4 only, it's because they're just not good converters? Because I know we didn't talk about how T3 is really the active thyroid hormone that does all the stuff in the body that you can really feel. But would you say that those are the people who would probably do well with a little bit of T3 as well?
It's interesting. There have been studies trying to see if that's predicted based upon blood levels, and so far it doesn't seem to be. So there's a lot of people who their T3 levels, free T3, total T3, are fine, are optimal, but they still may do better by including T3, or vice versa, or some that have low levels do better with it. And there's those that don't tolerate it. And that's also not as well predicted based upon blood levels. So blood levels of T3 and T4, there's often a real big misunderstanding between what they represent. So people often think that the TSH, T3, and T4 are all kind of looking at the same thing, how much thyroid hormone is there. They're not at all. They're completely different. So the TSH, I think about that as kind of like the gas pedal. This is how much your body is asking for your thyroid. You want to speed up,
Yeah.
or are you trying to let it slow down? The T3 and T4, that's like your speedometer. That's how fast you're going. And imagine there's a cruise control that's on. So if you go uphill, you'll hit the gas more, but your speed will stay the same. And you go downhill, you'll back off on the gas, but your speed won't change. So T3 and T4, they're regulated by your cruise control, by your hypothalamus, by your pituitary in a lot of ways. They're not the first things to show what your body, how much hormone is there. Now, at times like when you were given no medication and the thyrogen shots, your T3 and T4 could have been well below range when your TSH was up. And when you were over medicated, sometimes, not even then, in many cases, you can still have normal T3 and T4 when your TSH is suppressed. But if you're over medicated enough, they eventually rise. So there's a point at where the cruise control is broken. Like the hill is so steep up or down, you can't hold your speed. But between those extremes, T3 and T4 are what your body wants out of them, given what it has to work with. So yeah, it's fine to test, but the argument that you've got to keep them in a certain range, if someone does better at a certain dose, that's fine. But there's not really good predictive value of that based upon those numbers.
What are your thoughts on reverse T3?
Sure. So the funny thing is that T3 is not the only active thyroid hormone. T4 is an active thyroid hormone. There's things that only it does. Reverse T3, there's things the body needs it for that only it can do, especially within the brain. So yeah, and there's a dozen more thyronamines that have odd obscure names that all do things in the body as well. But reverse T3 is a normal byproduct of T4. We make more reverse T3 than we make T3. It's kind of like the way we have an extra kidney. We've got more backup there. And there are times where if someone is over medicated or they're ill, they've got a lot of reverse T3. But the high reverse T3 is not their problem. And the illness or the over medication is the problem.
And doesn't reverse T3 go up when you mentioned ill? Like if somebody's ill, typically that's the body under stress. If you're under consistent stress, would that mean consistently high reverse T3?
It can, but
It
the tough
can.
thing is that a lot of perfectly healthy people have high reverse T3. It's not always relevant. They did studies back in the 70s where they injected people with massive doses of IV, intravenous reverse T3. And it didn't block T3, it didn't cause symptoms, it didn't really do anything bad. So, yeah, when it's high, either it's not relevant or it's the body adapting. We see in critical care, like if someone has congestive heart failure or their kidneys are shutting down, they may have very high reverse T3 and a low TSH and lower T4. So the body is slowing the thyroid. And there's been debates as to whether this is an adaptation to illness or in some way if the illness caused their body to go haywire. And the most practical way of answering that is you can give people like that thyroid medication and you can change their T3 levels. And did that help them? And to date, it really hasn't. So we think it's more of an adaptation than anything. It's not the bad guy. We actually need it for our brains.
Let's get into T2. because there's a lot of talk about T2. And I know people supplement with T2. What are your thoughts on that hormone?
Yeah, so it's one of many biologically active thyroamines, and it has a lot of effects upon the metabolic rate and mitochondrial function and liver function as well. It was studied as a possible way to lower cholesterol back in the 80s and didn't really pan out as such. But we learned a lot from some of those studies. And what happens, it's what's different about it, is that it doesn't lower the TSH, doesn't change the TSH.
So it doesn't, what about T3 and T4?
Doesn't affect them either.
Really?
Yeah.
Mm,
Yeah, it's not T3, it's not T4, and it doesn't impact TSH.
okay. But it can impact metabolism. It can.
It can. Yeah. And studies have shown that if you take a whopping dose, you can raise basal metabolic rate. But that's a dose that's enough to start causing myocarditis and congestive heart failure.
Oh.
So, yeah, those that take enough, they start showing signs of cardiac enlargement and left ventricular enlargement specifically. But the problem is you wouldn't know if you were getting too much because your thyroid levels don't change.
Oh, interesting. But you would experience, sorry, you would
If you take a lower amount of it, there's probably no benefit to it, but also no harm. But if you take enough to be of benefit, there's probably harm that comes from that.
So it's probably better for your body to get your body to produce it on its own.
And that's the cool thing. If your body has a reasonable amount of thyroid hormone from medication or from what you're making, you've got a lot you can do to fine tune that. And that's where diet is big. And the biggest thing there again is iodine regulation. That's where having adequate micronutrients. And that's where nutraceuticals and phytonutrients can also help. They can benefit your body's capacity to regulate those hormones.
Okay, so if somebody's listening to this podcast now, they know that they have hypothyroidism because it's usually, I just know that obviously more people are diagnosed with hypothyroidism than hyper, but a lot of people would want to know, how can they start today to raise that T2 naturally? Other than, okay, iodine regulation, we know this. Nutrients. So we talked about selenium, we talked about vitamin D, just optimizing our nutrient intake. And then what?
Well, that's where, so supplements, there's those that the body requires and those that have beneficial effects upon the deiodinous enzymes independent from that. And that's mostly phytonutrients. So there's things that work on those pathways. And we see these from pomegranate, for example, and there's ellagic acid in pomegranates that benefit the capacity to convert the specific pathways of T3 and reverse T3 to T2 formation. We make more T2 out of reverse T3, actually. It's one more reason we need reverse T3. We don't make much T2 out of T3.
Oh, interesting. Okay, okay. That is very, very cool. Okay, I think we're over. Oh, we are. We're over an hour. As you could see, I could talk about thyroid like all day. What else would you like to add that we haven't touched upon? Where can somebody start? I know you have so much through your website, but let us know if there's anything you want to touch on before we close off.
The main point is that whether you've got your thyroid or not, whether you got a clear diagnosis or not, your lifestyle changes can make a big difference. There's so much data that those that still have a thyroid often don't need medications, or those that have changes in function can often reverse that. And those that are on medications can respond better to those medications. So, yeah, after 30 years of managing a lot of people with medications and without, there's so much more than we ever thought from diet and lifestyle. So, the Thyroid Reset Diet was my most recent book on this topic. And it's a very simple protocol. It's not even restrictive. There's a lot of food categories you can have. People often do launch into extreme diets for thyroid care. A lot of extreme diets have been tested and don't help. But this one angle can make a big difference.
Can't some of the extreme diets also hinder thyroid function?
Well, and they can also be difficult psychologically and nutritionally. It's hard to make the diet too radically altered.
Yeah. Okay. Well, where can we find you, Dr. Christianson?
drchristianson.com, easiest place. That's my main website. And yeah, thousands of free articles and blogs. The Thyroid Reset Diet, wherever books are sold, it's a great way to get some details as well.
Perfect. Thank you so much for your time today. It's been a pleasure.
Well, it's been good to talk to you, Sandy. Some real good questions.
Thank you. I hope you enjoyed this episode. Be sure to share it with someone you know might benefit. And always remember, when you rate, review, subscribe, you help to support my content and help me to keep going and bringing these conversations to you each and every week. Join me next week for a new topic, new guest, new exciting conversations to help you live your best life.